about a case NQAS and NQAS particularly in primary health centers in rural India with reference to the quality management. As you all know, our main focus for quality management discussion is more towards infection prevention control practices and patient safety. So we'll have larger discussion what is national quality assurance standards, what are the different key sets actually that makes NQAS uh, a difference from NABH. In the previous live session, we have talked about NABH. We spoke about how NABH is important, what makes a difference. And the case study that was given of a private hospital gave you more insights about what NABH is. And now when we are trying to talk about NQAS, which comes from Ministry of Health and Family Welfare, and under the guidance of NHSRC, how it has developed and how NQAS has really seen key shaping the quality in the public health institutions across India. So as you all know, quality in healthcare is not just a standard. So it is being seen as a commitment which is towards the safety, a commitment which is given towards the effectiveness, and a commitment which is more patient centered. So three of these key areas, the standard revolves around of quality, especially for a patient who is coming to a rural setting, particularly PHC and CHC. We keep more importance that the primary health centers finds to be the backbone of the public health system of our country. If we quote the recent national health policy, the third national health policy 2017, which highlights the transition of the healthcare delivery in our country, with expecting the more burden of non-communicable disease, which is being increasing, and the pending burden of communicable disease. So the key highlight of today's session will be more focusing on the need of primary healthcare and the primary healthcare, how quality and quality implementation needs to be taken. So as I was quoting of National Health Policy 2017, it gives again us a recall for the Bhore Committee report, which highlights that there should be more importance of primary healthcare if we need to handle the load of the public health system in India with the increasing population. So today's session is to explore how National Quality Assurance Standard, that is NQAS, are implemented at a grassroots level and the challenges faced by these institutions, which makes more reasons for us that how this transformative impact on infection control practices, patient safety, and overall healthcare delivery takes. So I encourage the participants to actively engage, to take down the notes, also to reflect and contribute to the discussion. If you have any query, we will put it at the end of the session. So let's begin with this session with an commitment of improving quality, that too with the lens of keeping rural India in mind. So when we talk about quality, the very first important thing which comes in our mind when we talk about NQAS is like quality of care, which has emerged through the lens of NQAS. I'm trying to give you more insights, is being emerged as a trust. And the trust is more, which is being given both from the policymakers and the public health practitioners, where we are trying more to talk about the healthcare providers. So the quality of care is served as an instrument and which is more for the optimal utilization of the resources that are being used in public health settings. So public health setting, there is no such as a question about resources as being present, but the utilization of resources also plays very important role when we talk about NQAS. Also, quality of care in these institutions is more to improve the health outcome. Along with improving the health outcome, as always, any quality healthcare institution always thrive for is patient satisfaction. So when we think about NQAS, providing the health services without guaranteeing a minimum level of quality is very ineffective. So we cannot say that you are not guaranteeing quality and just providing the services which are ineffective as well as even unethical also. There are two things. So trust is one a very important key area when we think about quality in NQAS. Okay. So it is very important that all the public health institutions, public health settings, public health facilities are to be benchmarked against some set of quality standards. So benchmarking is one which makes more effectively understanding what the public health institutions are going through the NQAS implementation. So to improve the confidence of the public health institutions, to improve the quality of the public health services, and to boost the morale of the service providers, particularly the practitioners who are there into the field and working into this institution, maybe a sub-center, primary healthcare centers, so or currently what we call them as Arogya Mandir. So the high quality system which is augmented with the efforts of Ministry of Health and Family Welfare and NHSRC Delhi, it is given in context that all this delivery care which we are trying to see that it should improve or should give better health outcome are valued by the trust. So responding to the changing population need, as I stated that we are having the need of NCD also, which is coming now in primary healthcare, along with the infectious disease role. Ideally speaking, primary healthcare are being seen as a front referral units. Most of the activities which are taken in primary healthcare centers are more being seen as something which is making us more realize that what best possible ways that the institutions or the public health institutions are doing. If we see the journey, it is more putting us actually to the different interventions that these programs have gone through. Maybe uh, the reports may be coming from the states, may be coming from the different union territories. We try to understand that the interpretation of the National Health Policy 2017 clearly puts up the impression that the state particularly has to take the whole responsibility of this quality of health services. So it is again like a public health responsibility which is coming to the state, okay, and the union territories, and it is an objective and imperative actually to improve the health status. So what is the way of doing that? The way of doing is that to concentrate on the policy actions which are derived from the NQAS set. So it is applicable to all sectors which may be stating the needs of a preventive, which may be stating the needs of a promotive, which may be even stated to fulfill the needs of curative and palliative. Okay. So because our focus majorly in public health is more towards curative aspect, which was traditionally being seen. And so a lot of the approaches or successes that we have seen in public health is more from a curative. Preventive and promotive is something like we are doing it more rigorously now, and most of the focus of the 70 or 80% of the share that we can say that public health institutions are offering, which we are stated to be more because of more curative successes. But preventive and promotive are like in the last 2 decades that we have played more importance to. But in the coming days actually, and the increasing aging actually in our country, and the need of social security net and welfare, we have to even see that we need to even provide rehabilitative services, which are more important into the areas of NCD, particularly mental health, drug addictions, and so a lot of. So, what is the target that the NQAS is putting? It is putting that there should be universal access to good quality of healthcare services, and along with that, without anyone having a face of financial hardship. So, we have a inclusion of program called as Ayushman Bharat. Ayushman Bharat is a system strengthening program, and the consequences of availing these services should not put anyone in financial hardship is the whole and sole purpose of this program. So this would be achieved by the healthcare providers, by the public health institutions, by the increasing access to the people who are coming with a need of only services, but improving the quality of the services or lowering the cost of the treatment actually that the government has to do is the whole and sole purpose of the healthcare providers. So let me just give you a brief history, and then I will go to the proper case study, because case study on NQuas particularly will require for this audience to understand what NQuas especially is. We have already covered in our sessions, all the in the 60 sessions, we have even covered this aspect also, but particularly I want to make you revise actually what NQuas and how NQuas takes to shape the role of quality in major of the institutions, and how NQuas has contributed to be seen as a major success, particularly in the healthcare delivery of public health institution. The National Quality Assurance Standard, which we stated as an NQuas, was launched in 2013. And this was a year that we put that there will be a scope that Indian public health institutions will be seen through a quality lens. And the standards that are developed over there are not only for district hospital, but are even for community health centers, primary health centers, and even urban PHCs. Okay. And over the period by 2020, or in the after we completed the burden of the COVID, the standards of Ayushman Bharat Health and Wellness Centers and sub-centers were developed and evolved. And now we have this Health and Wellness Center to be called as Arogya Mandirs. The imperative of doing this activity was more for quality of promotive, preventive services of primary healthcare. So we are not bringing completely curative as such in the primary healthcare. No doubt for the NCD part and all that, what I have spoken is more for early screening, identification, and proper timely referrals. I'm putting it three very important words over here. What is the purpose? Preventive and promotive. Okay, these two P's are very, very connected with the PHCs. So it makes the three P's. Okay, not the three P's like of public-private partnership and all that, or public-private mix, that we will discuss it later. We will have one more session if possible. So we will make it more discussion on like how quality is taking the shape for that also. I'm planned up with that. So we will take that in the further chapters. The purpose of PHC is actually is early screening and identification and regular follow-ups. Regular follow-up is very important, which though although otherwise many times we are not seeing it, or it is not followed properly. But timely referral is very, very important. Timely referrals to the secondary settings, or timely referral to the tertiary health centers. Okay, hospitals, particularly medical college teaching hospital. So the NQuas continue to meet the global benchmark, and which is with the International Society of Quality in Healthcare, that is our issue. That was made in 2024, last recent 2 years only. But the operational guidelines for the quality assurance were made in 2013. And all four levels of assessment were planned. In the initial stage, it was planned with the facility level, district level, state level, and national level. So to get a certification for the healthcare facilities, now it is being seen that you have to show an exponential growth. And we have seen that in the last 5 years, the quality improvement division of Ministry of Health and Family Welfare, the quality improvement division of NHSRC, particularly which comes under the Ministry of Health and Family Welfare, and the regional resource centers across India have persistently taken efforts to give quality assessment and increment into the process. So what has been seen as an impact? The impact has been seen with respect to the different processes that have gone through certification. All the zones, southern zone, northern zone, west, central, eastern, and northeastern zone have also shown a very remarkable efforts into the quality implementation part. And this has been one not only with the restrictions of that most of the private setup is more into the regional setups, particularly where already there is a spread or network with respect to educations and institutions. So they have flourished over here. But for rural health, public health institutions are the only one which are more to be relied on. And we find that the certification or the implementation process which goes with respect to standard practices of infection prevention control or even targeting and making all the quality teams or quality circles particularly have to go with a proper training. The training may be more of biomedical waste management, or training may be more of particular quality, or training may be going for a specific program. Even Kayakalp is one an initiative which is an expression that the WHO's initiatives of putting definition of health in a very constituted way of expressing that how merely absence of disease or infirmity is not only the one thing, but even concentrating more on the social well-being part, which is having a linkage of hygiene, sanitation, and improving the better health outcomes. So we have to even see about the guidelines which are being taken in consideration for the NQAS. So NQAS plays as a more wider role to understand the needs that Indian public health institutions are taking, and the percentage of the primary health centers which are making efforts, and even the efforts like Mera Aspatal or My Hospital initiatives were also being launched, and the objective was more of improving the patient satisfaction. And further, their objective was added with improving the quality of the healthcare institution. So you can understand now like how the primary healthcare institutions which are established now are being seen with an augmented, I'm saying responsibility with patient driven or even responsiveness that they have to put, or even an accountability which has come with the decisions that are to be taken for improving the quality. The mechanisms that are being implemented are not only being seen that all the states or all the UTs are taking, that you are making it more that the data that the institutions are keeping is not only of improving the patient's health outcome, but are also scaling up the institutions. So scaling of the institutions are also very, very important part that this is being taken up. When we talk about the implementation, we need to understand that NUHM is also being seen as a very sub-component which is being taken into consideration, and not only the rural part. Today's discussion will be more focused on the rural health setting, and in the last decades that we have seen that what this quality has brought as a benefit, especially in the primary health centers efforts, which has made it see the health indicators, particularly I'm talking about MMR, maternal mortality rate, and even infant mortality rate, which has been drastically being seeing success as. I'm not saying that it is only with the operational guidelines that NQAS has put, but it is also with the improvement into the training programs, awareness programs, also by scaling up the institutions which are making the problems of the public health institutions which were more coming from the efforts by the ministry that has made these institutions more sound. Okay. So now when we are trying to talk about the case study that we are supposed to concentrate more here is more about a case study on implementation of NQAS on the in the primary health centers. So now I want to give this case study to you, as this case study stands to come from the rural settings, and I've given you a background like how our primary health centers are and what are the purpose of a primary health center. But this particular case study comes with an institution which is a NQAS certified institution. So you can understand the plot of this PHC. And this PHC is a PHC which is providing a care delivery, catering to a population of near about 25 to 30,000 population. Okay. Ideally speaking, this is a huge load to a PHC, but this is a very full-fledged PHC. And this PHC is providing OPD care. Additionally, with 5 beds fully functionally of IPD, which somewhere or the other, the occupancy comes more than 80 to 85%. Also, this particular PHC is providing maternal child health services. This PHC is providing immunization and all national health programs implementation. Okay. So the primary health center initially was facing a, a facet of multiple gaps actually. So the gaps were more respected towards only the quality gaps. As we are trying to take this case study for quality understanding, and we are trying to more focus on this in this case study on infection control and patient safety aspect. But along with infection control, here the component of infrastructure issues and clinical processes are also being seen. The reasons of putting this off along with infection control and patient safety is that many times what happened, the clinical processes, the infrastructure also contributes to the quality gaps. And to address these issues, the facilities are being seen through what are the improvement that the NQAS is being stated to give us. So the NQAS, as you have are now well aware, that is a very structured framework. Okay, and NQAS is majorly covering 8 areas of concern. Okay, what are those 8 areas? I will be covering to you. And among the 8 areas, infection control, quality, infrastructure, and all those are very, very important. This case study primarily comes from the NHM Maharashtra, and we will try to understand what are the imperatives that, according to the states and all that, will come. But I will try to focus more on the key quality issues before the NQAS implementation this PSC was having. Okay. Okay. So this particular case study before the implementation of NQAS, we'll try to understand what are the issues this case study was uh, focusing to see about this PHC. This PHC particularly is not into the remote area, but it is one where we find that there is a good connect of the referral units. But in spite of that also, what made an issue with respect to the referrals and the infrastructure gaps actually, which made more problems of this PHC. So the key quality issues before the NQAS implementation, which has started already now, this PHC is NQAS certified. But before that, and this is what is my own observation that we have seen with this. So I want to bring it to my students over here about this NQAS implementation that has made major. The very first issue which was observed of quality was of infection prevention and control. We call it as IPC. And in the IPC, we saw as a quality assessor and as we can see it, it was more the poor hand hygiene compliance. It was so much that all the washing stations or no solutions, nothing was there. Locally seeing only water or sometimes a dry soap that also not good condition was being paid. Alcohol-based sanitizers was not there, and no monitoring of hand hygiene practices or something as a leaflet or some signages or even the positions were also, and free running water was not available. Okay, so this was one thing of poor hand hygiene compliance. Second is was inadequate biomedical waste management was an observation that was very primarily been taken, that color coded bins were absent. Okay, sometimes whatever was there and the faded colors that were there, the segregation was not done in a very proper order, and you can say that was a major mismatch actually into this facility, that this facility was not concentrating on, and which was a major issue of infection control practices, especially which was giving a major reasons of patient safety. Okay, and the inclusion into the biomedical waste management, you can think about, there were a lot of disposable practices which were creating infection rates actually, which was being seen that lot of infection which were coming from these institutions, as if like you can say with respect to the smell or by the disposable or by the transmission were more being projected when we took about the entire assessment was more because of the unsafe disposable practices. Now I'm talking about the third area. The third area was more of sterilization and disinfection gaps. So how we come to know that because the autoclave was not used properly. So we can say that irregular or very improper use of autoclave was done. And the logbooks which were there for the sterilization records were not in order. Okay, so you can note down actually, and you can even guess and make a map actually, like how when you will see yourself as a quality assessor, what are the important things that even a sub-center, a small unit or a clinic should have. Okay, use of improper disinfected equipment. So whatever disinfected equipment were there, cleaning, sterilization, disinfection, when it was not done properly, you can say this is being seen as a major disinfection gap. Disinfection followed by sterilization. Okay. And now when we talk about the other environment, especially the internal environment. So the internal environment, particularly with respect to hygiene, I mean to say particularly for the healthcare workers, the doctors, the healthcare workers, nurses actually. So they were being seen with very poor cleaning protocols. Okay, poor cleaning protocols, especially into the labor rooms, and even the lack of infection control practices was being identified when they showed their infection control record, particular register. The checklist part and all those were not in connection actually. Whether they have made checklists with respect to any interventions they were trying to do or medical interventions, it was not being seen. Okay. Additionally, the absence of ICC, very important. There was no structured infection control committee. No infection control program was designed. No particular person was taking the charge of this. Okay. So when we find that such of these activities are not done, how these institutions will prepare for NQAS? Okay. So because for NQAS preparation, you need to have a preparatory plan. You need to have an internal quality team. You need to have a quality circle, and the quality circle should project on developing infection control protocols. Okay, so infection control, ideally we say that it is something a very dedicated and influential, I am to say, creating an impact activity. And infection control is a very dedicated way of handling the issues of hand hygiene or even sepsis, we can say antisepsis, or the personal protective equipments of yours, the equipment processing part, which are more with disinfection and sterilization, and even biomedical waste management. Okay, so these all are the very fundamentals that either a person of a quality team or someone as a nurse who is taking as an quality control activities need to have this in mind, that these are the very important areas to be focused more on infection control practices. Now, additionally, we want to see what is there of patient safety issues these institutions have faced. I will answer most of the question because it is not possible. I will put all the questions of the chat. I will answer once I finish giving you the discussion on this case. And this is very similar to the problems most of the PHCs usually face. Okay, and similarly, you may find that whoever are working into this PHCs who are working in government sector, they can understand what are the issues that they have to more concentrate on. Okay. The patient safety issues majorly which were observed were of medication errors, incorrect dosing due to all the prescriptions. I can put it as illegal or improper prescriptions which were not being seen as a prescriptions under the quality management lens. Okay. No double check system, no verification, no proper way of meeting to reduce the medication errors. Okay. So I count this as a very first and very important patient safety issue, medication error. Okay, medication error, as you know, leads to major medical negligence, and what are the implications of that is well known to us, which can lead to major consequences. Then comes patient identification error, which was also being seen through our assessment. What are the indicators for that? The indicators was that no standardized patient identification protocol was followed. You can see that when a system, a particular healthcare setting, doesn't follow a patient identification protocol, this creates more errors in terms of meeting the patient's identity, patient's confidentiality with respect to information, and so lot of safety reasons that it can give you major problems of patient safety. Very important. Compared to medication error, this is also very important problem of patient identification. Okay, many public health practitioners face this issue that they are not able to maintain or to reduce also, at least to some extent, patient identification errors. And the very third, very important with respect to patient safety was unsafe injection practices. Okay, what was the indicator for these unsafe injection practices? It was that occasionally, whenever they are using the use of this syringes and all that, they were not doing proper reuse, or they were not sterilizing, especially for syringes which were being seen whenever they used the fresh or syringes, the disposable was not done in the proper way. So syringes with equipments and all this, which was making little a disguise to us to understand what these practices really are going to. So we made three major indicators of this, which were connecting to me as very much investigative and to the other team members to understand what are the patient safety major concerns that can face. So with the documentation part, it was utterly poor, that all the near miss events and all those adverse events were not being taken or reported, or there was no report coming of that. As you all know, that PHCs are always very timely, responsive referral units to be stated as. So for emergency preparedness or even emergency referral, there was no even a proper cart actually, or maintenance of a record was being seen. No staff was well dedicated to or trained also to understand what are the emergency response. Okay, we are not stating that it should come as an emergency department level of response, but at least to understand whether a case to be identified or even some level of primary triage training should be there. And lastly, very important issue was of no role of patient rights being seen as. So as if like the patient consent, patient's privacy, patient grievance, and even patient's relatives grievance with respect to the patient need was also completely sidelined or was not taken in consideration. So this was making us more reasons that these all areas, all the 5 to 6 areas which were pointed out after the assessment of the team, external team which has made to this PSC, came up with a framework actually that when we have to develop and plan actually that this particular PSC, the NQA should be applied, what are the things that we need to do. So as NQAS evaluates the facilities based on all the 8 areas of concern that I have discussed, the lastly when I put the patient rights is also very, very important. And nowadays when we have the charter of patient rights and responsibilities, it is very important that you have to focus on this as one of the area of concern. No doubt the very first area of concern comes as a service provision, where service provision is the very essential and very important, that it should be into the essentiality, accessibility, and affordability. These three things are very important in the service provision part as an area of concern. Along with that, you should have a proper infrastructure that we can say input, throughput, and output. Output will be also evaluated from the patient satisfaction point of view, and the input here will be the infrastructure of the PHC, the human resources present in the PHC, and the equipment in the PHC. So after system service provision, inputs is very important. Throughput will add more with the processes part, and output will be more on the outcome or service delivery with respect to the improving of the health indicator, improving of the major clinical indicators, improving of the facility indicators. Okay. The third area is of support services. All the support services additionally with the clinical services that are being provided. Then comes the clinical services. So I put support services in the first range compared to the clinical services is that the importance of support services is very much in a PHC compared to clinical services or more than the clinical services to enhance the quality of clinical services, to improve the clinical services. Okay. Additionally, there is one an area of concern is of infection control, then quality management as a separate, and also patient rights. Okay, these are all 7. What is the additional outcome? According to the NHM Maharashtra or NSM, what are the outcomes that will be taken as very, very important? So there was a gap analysis that the NQAS assessment process prior needs to do if you have to start and work for a PhD to take this as an action plan. What is the baseline assessment? You have to do a gap analysis or a way that you have to go for a quality management tool. So what is the quality management tool to be seen over here as? That your team need to do either a RCA, root cause analysis of all the things that we have understood. Whether it is a need of an internal committee to be have, whether the facilities have some issue, or whether on the basis of the patient's outcome, you have to take this major concern. Okay, so the internal team needs to be prepared. That is called a quality circle. So quality circle was prepared with people from different ends of the PHC member, not of same stretcher. Okay, from the top to down. So there was a method actually to identify that people who are more interested to take the responsibility of the quality were being given more chance, and rotation was done to give training to the other fellow colleague after that. So when the internal team prepared the work and they started to conduct the self-assessment using the NQAS checklist, which is provided under the NQAS guidelines that have been given, they made an effort of identification of the gaps. The gaps were more coming like how the gaps, whether it is a man-made machine of mechanics, actually of equipments. So the IPC, the infection prevention control gaps, patient safety gap, and clinical services gaps were identified. Again, I'm putting here clinical services at the last because clinical services is not the purpose of PHC as first. The purpose is more of promotive and preventive level of care. In preventive level of care, clinical no doubt comes important, but clinical services is the last. Okay. So in the first step, what the NQAS planning committee they did a formation of internal team for quality. They identified the gaps of the PHC. Gaps were with relation to infection control practices, gaps were with relation to patient safety, and gaps were related to improving the clinical services. Okay. The second step was formation of this quality team to enhance. The quality assurance committee was enhanced by establishment of more specific members into it. What were those members? The members were of a nurse who is well dedicated on working on the infection control practices and having or keeping a record and improving the protocols, identifying and making more good proper indicators, and making monthly meeting for that, working on training part and all those things, which is very, very important. What is the reason of making this? Because this will help for the next level or next step. When we talk about all the 8 concerns areas in QoAS, it is very important that implementation part is very important. So in the implementation part was more with the standard protocols. The standard protocols or standard protocols, standard operating procedures, protocols of developing SOPs. Very important. SOPs needs to be developed, or if though there are some SOPs which are there, needs to be augmented. if you find that there is a major gap. But for this particular case, we identified that the SOPs were developed by the team, especially for hand hygiene. Okay, SOPs for hand hygiene, SOPs for the biomedical waste management, SOPs for the infection that were more coming because of the unsafe injection practices. So infection which were coming by the injection were more dealt with the safety injection practices. Okay, so तीन चीजें यहाँ पे important, three things are important. But as you know, at the very start, what I have discussed, there was patient identification problem more. So patient identification problem was giving you more reason that the SOPs need to be developed according to the patient identification improvement. So standard operating procedures, actually the standard protocols were being seen aligned to the SOP. Now, after the SOPs were being prepared, stated, and were being revised actually according to the need, the part of training and capacity building comes. As like how we are going actually and imparting you the same level of training with respect to NQAS was done, and for the PSC particularly which they have received at the regional centers actually, where the people, the healthcare practitioners were trained. What was the training that they were primarily they have to receive or they need to focus? The training was more on infection prevention practices. Okay, infection prevention practices and patient safety protocol. Okay, patient safety protocols might be something actually of fall, might be of hit, might be of wrong injection, and too many other things actually which will give patient safety protocols to be aligned to the indicators if you are facing and any event. Okay, then comes developing the team for giving a proper or receiving a proper training if though they are not skilled for biomedical waste management, and when they have received it as a training, they should impart to their people. They should make more efforts to improving the signages part, well dedicated areas, putting up the equipments, and also maintaining the biomedical waste management and abide to the rules of biomedical waste. Very important. Okay. Then comes the mid stage of internal committee to take quality assessment. Okay. We were being seen as an external assessment or external assessor. What is the internal assessor over here? The internal assessor was doing a periodic audit. In this particular PSC, the periodic audit was done after 7 to 15 days. Or they were being seen as at least in a month, one periodic audit was to be justified. So the measurable indicators that we have already stated and more indicators that they developed and then they documented it properly. The evidence was provided to us, which was very promisingly, very satisfying. Now, after identifying and fulfilling, what are the areas actually that has shown improvement? The areas that have shown improvement to the external assessors was like the facility has to be evaluated by state level facility, and the facility has to meet the scoring compliance, which is most important part, that whether to get a facility certified, it should equivalently come or it should be higher more than achieving a 70 percentile of achievement. 70 percentile of achievement. It is like you are expecting them to come into the distinctions. Okay. And the certification which is being provided is more by the continuous monitoring effort done by the internal committee. So now you can understand the role of the internal committee is very, very important. But after receiving, or suppose in case you are passed through this, your certificate will not be for the whole life, or the certificate will not be for number of years. It will be like the certificate will be valid for 3 years, and the validification will be done with a periodic, or I mean to say an assessment after a assessment which is being followed by the state with respect to the self assessment followed by external assessment model. So you are saying that there is an evaluation model that NQuas emphasizes on. NQuas emphasizes that if we have to go for a quality in a very regular way, or I can say continuous quality improvement, CQI. Okay, and CQI or continuous quality improvement is being seen that should be taken well care by the institution and not by the external agency. External agency will come only and only in picture when you have to get a certification. Okay, is that clear? So what is the model? Model is of self-assessment by the internal quality team and final evaluation by or assessment which is done by the external quality team. But the corresponding or initiating or what I can say, someone who can coordinate is completely by the team which is of quality in the particular fields. What are the interventions that were done with respect to infection control, infection prevention control, and patient safety? So control provisions actually that were seen that you have also come to notice that hand hygiene proper वहाँ पे नहीं था, that was not there. Sanitizer was not there. So installation of instant hand washing stations where there should be running water, there should be a basin, there should be sanitizer, there should be even for very proper gynec and surgery conditions. Actually, if the PSC has to do some minor all those part, they need to have a very proper sanitization protocol. Okay. Now coming with the biomedical waste management, all color coding bit installation should be done with respect to signages, proper training for that part, and strict biomedical waste segregation should be followed. So this is one of very important intervention, and all PSC need to go with this intervention timely and review also to those. Okay. Autoclave validation and sterilization, because if though they have a functional proper done autoclave, they need to maintain the labor. They need to maintain that all those things of the ledger that or register or a logs actually that you are maintaining is not only of maintaining when you have done it. Actually, it is like how much load it has come, when it was done, what are all the belongings that are coming are needed autoclave or not. Okay, you cannot exhaust the resource, but you should also improve the resource. Okay, physical way, if it is pointing that this particular healthcare worker is not doing, the prevention can be taken in a line that the healthcare workers are not following. So you can even see and go and do the work by verification that what are the logs maintained to please show us. So the regular fumigation, environment cleaning protocols, nothing was followed and the interventions were now made with respect to this pointer section. Okay. And as I already stated, the emphasis of infection prevention and infection prevention control committee was there. Infection Prevention Control Committee made more emphasis or the directions which they were given, and but what I recollected is more that they were given more on the part of mask and gloves that we wanted actually. Even gowns were also being very important, or apparels were being also seen. So now I will come on discussion with patient safety interventions. Okay. Unique patient ID was introduced, which is very important and landmarking introduction into the set. Standard treatment guideline displayed when the patients are coming and when you are not able to meet up their requirement and all that, which will affect actually the standard treatment. So standard treatment guidelines might be with this one example and many such examples which are there in the standard treatment guidelines, particularly for the students actually who are more into the sub-centers, PHCs actually, they need to understand that double checking medication is very important to reduce the major other side of load. What is the major other side of load? That is medication errors actually. Okay, personalized errors. So in emergency standardization crash cart actually, we need to see that whether any emergency has come, whether the emergency was handled properly, which is the facility that has handled this emergency, and whether patient consent and patient's rights has been taken care of or not. If though it is not taken care, it will be seen as something like it will affect your NQAS outcome. Okay. So now what we'll do, we'll take a quick break of 5 minutes, and again I will resume back. Don't leave the meeting room. We will continue with the same. Meanwhile, I will even go through the questions that are, I will answer those, and then we'll move ahead for the remaining part of the case study. Okay. Resuming back. So now when the internal quality team has made all these efforts, they have made the implementation and they have completed the task of NQAS, and all these quality assurance that were being seen as a benefit to this particular PSC were giving some level of outcomes which as an internal team has already um, able to verify it, or the team is able to see that these are being completing. So our main focus actually for as an assessor were more pointing that okay, what are the facilities they have, in what respect the facilities are giving quality outcomes. So the improvements, particularly in infection control area, which were seen by the internal team and later by the external assessors, which were by the state level, was significantly increased in the hand hygiene compliance. The reason was that the gaps actually for the hand hygiene, which were being seen as a lack, were completely fulfilled. So a major change in the provisions, particularly of the infrastructure level, improving it, giving them a training, provisions of the soap, water, particularly, and even alcohol scrubs was not provided, which were being said. But yet the improvement was done. So the significant increase which made the reason that gave a compliance that yes, hand hygiene has a major role actually when you treat infection control as a prime concern of area. What is the resultant of the improvement of hand hygiene compliance? The resultant of improvement in the hand hygiene compliance was more reduction of the hospital acquired, or we can say healthcare associated infections. So the acquired infections that the patients were taking were being seen more as the contact, and even the contact to the healthcare workers, the infections are more common. So that was drastically reduced because of no incidences, and even being understood as by the internal team also. Because the more relying factors were coming more from the records which were being seen in comparatively very much improved. Okay. The major success was being seen by the NQAS implementation was of the biomedical waste management achievements, which were to be completely, I mean to say 95 to 90 to 95%, it was complete. Okay. Clean and hygienic facility environment was being seen, and it was making us a not only an ambience but also being very much important. What are the three areas? Hand hygiene compliance and reduction with respect to the incidences and practices of sanitation, disinfection, cleaning, disinfection, and sterilization. Proper biomedical waste management. Three things which was a game changing into the infection control practices, IPC. So the improvement was giving more reasons to come up the facility which has achieved actually to receive the certification by 70 to 75%. What was the second area? Improvement into the patient safety. How can we understand that a patient safety improvements are being seen? As stated, patient safety improvements can be only seen with two important areas. One is the medication errors reduction. The more number of medication errors, more patient safety concern. Reduction in medication errors and procedural errors. How we start, how we do the process, how we do the procedure, what is the end of the procedure. If there is any such as an medication related, either it is an IV, whether it is an intramuscular injection or it's a handling of any treatment, which is making more reasons that you are not following the medication properly. It was giving reasons for us to give more chances. Okay. So when we come across actually these issues in any institutions, what we usually suggest as a quality manager, we usually suggest that what is your patient's actually response to this, whether the patient understanding or patient's not understanding. With respect to the health literacy and those part, and even ignorance from the healthcare providers, majority of the time what is being seen as patients response of patients um, feedback is nil or sometimes no. I'm not saying dissatisfaction. Many times to get a dissatisfaction, sometimes is only being seen with respect to availability of the healthcare provider or availability of that services. Majority of the patients really are not in a position, if though although otherwise they are being admitted. IPD patient can tell you more reasons of quality. But sometimes 5 to 10% of the major issues that the patient faced were of their responses, emergency responses, trust of the providers, unavailability of the providers. Even though the procedures or process was done, that was also not incomplete. So patients were able to give some level of responses that I understand, but they will not even able to completely give us the information of patient satisfaction that was informed by the quality team. So the improvement in patient identification was also being drastically seen as an improvement thing, and emergency response was also being pointed. The emergency response was readily being seen with respect to the referrals, identification of the patient, transfer of the patient, understanding the specific needs of the patient was things. And very importantly, as an quality assessor, which comes into role from the state, particularly, which gives us more reasons that sometimes when you are doing an assessment, we have to additionally, apart from infection control practices and patient safety, you need to also see the system level improvements. So we'll say, what is system level improvements? System level improvements are standardizing the clinical processes. Most of the medical practitioners actually who work on standardizing their processes don't face major issues of quality. And so where their institution will also benefit, their patient will also get a reduction in patient safety issues, and ultimately it will solve the purpose of quality. So standardization of clinical processes was done with respect to their practices, SOPs, standard treatment guidelines, the drug formulary, and too many clinical indicators which were improved, which were giving the clinical processes. The very important and very aligned to the clinical processes system level improvement is better documentation. In quality, documentation is very, very important. We saw in the previous live sessions that how NABH, entire NABH process success is completely on quality documentation. In NQAS also, documentation is not left, but NQAS paves more important on doing a better documentation, as if like record keeping. All the things that whatever work you have done, if you are doing a record keeping, it is very important that you can even assess and improve on the basis of the work that you have done, whether it is done or not done, whether it is complete or incomplete, whether if it is a complete, to what level it is complete, everything will be seen as. So quality improvement at system level will give you a chance whether your work is done through your documentation. Okay. The very important and part which may be sometimes very difficult for those healthcare workers who are newly joined or temporary people and all those is of when the quality assessor, internal or external, they will ask you with respect to your accountability part or improving the accountability part or teamwork, whether your teamwork, whether your accountability will play a major role in contributing to quality or not. The answer of the question is like improvement in quality practices or quality management practice is only and only when you try that your staff is paying more important towards the accountability. Okay. And teamwork. The teamwork is more important, which is not possible without changing the attitudes of your healthcare workers. Understanding that you own this facility, you have to work with the quality as if like it is giving you more benefits and uh, uh, reasons actually that your facility will be certified and the impression of the people will be changing, the trust will be gained, you will be more seen as a responsible person. So you have to apply all those motivational theories. Na? Even you have to even make sure that in your training programs, your BCC model should come, behavioral change communication. Okay, Maslow's theories interpretation properly should come. Strengthening the referrals, understanding the needs of your healthcare workers, follow-up systems actually to be understood with respect to how you are to change the needs. Because healthcare workers need not to be ignored their needs. And ultimately now the final outcome will come of the case study. The final outcome is that NQAS, as we have seen, is more towards assurance part. You know the Juron's triology, how it starts with planning, control, assurance. So now NQAS over here in this particular case study and even NQAS efforts actually in implementation always impacts healthcare quality on three dimensions, which I am revising you again. What are the three dimensions? Safety, patient-centric, and standardized care. You can say comprehensive primary healthcare achievement will be done only and only by three standards or three segments, which is more on safety part, which is more on patient-centric approach and standardized care. Even the National Health Policy to 2017 also uttered the need of patient-centric approach. Okay, where your consumer, customer, or your patient, whatever you put it, you have to take care of the needs of the patients with focusing on their priority as first. So patient first should be the priority. The impact of the NQAS, particularly for this facility, was being seen. As I stated, reduction in infection was there, reduction in medication errors was there. Although otherwise you can say reduction in the clinical processes that they were doing were poor, they have improved, and the patients were able to see more trusted care. So there is a great improvement. The promotion was done of this to the next team or continuing team or someone actually for the days actually how you have to take this. So you have to develop a continuous quality improvement program. What is the continuous quality improvement program? The continuous quality improvement program comes with the development of culture of quality into the employees who can take this activity regularly every time and every time in a very improved way or more added and making it more perfect. Okay. So the culture of quality and culture of patient safety. So the promotion should be more on that part that every employee, whoever gives duty change or shift change or even changes from this one facility as a transfer, the next person should be given the training for that part or has to be sensed with the culture of that. So you should develop what? A quality culture. Okay. And one more addition into this I want to make, which makes a great sense. The credibility part to all the public health facility will be seen enhanced only and only when you give them the sense of responsibility. So we'll say it's an individual part, no doubt, because this is being seen as a great challenge. Because when we count out all the successes, we should also see what are the challenges. The challenges is like to put the responsibility. So whose responsibility it will be? It will be the responsibility of the head of the PHC, the RMOs, the medical officer, okay, and all the district health officer, CDHO, DHO, na, all this. They will have more, and even the quality team at the district level, state level. Okay. So additionally, there will be some challenges also. ऐसा नहीं कि challenges नहीं आएंगे. There will be challenges like resistance to the change, particularly for the staff. Some staff may be older. Some staff may be something actually with their generational gap and understanding and all those things. They might be thinking that why we require quality. What is the reason and how and what is this benefit giving to us? Whether the work that we were doing previously was not done right or wrong, and what this quality is really being giving to us. The private sector resistance comes in a very different way, because in private sector the resistance comes because they have to pay more, the cost more to have put more people into this. In public sector, the challenges of quality implementations are little different, or I mean to say more different. The resistance comes because the staff mostly get redundant actually, because they are mostly permanent staff who gives more resistance. Even temporary staff doesn't found it as an accountability, because they find that my work is more for a certain time period, and why I should change. So resistance to change is very important challenge. And the very second important challenge is of limited human resource. Most of the people might have faced this. Doctors especially, they face lot of issues because of limited human resource, especially to their subordinates and to their other health assistants, actually nurses and all those people actually into the public health facility. And no doubt, the very third and very important, which I could have put it at first, that Indian public health system face major problem of infrastructure constraint. Infrastructure constraint is the one biggest problem apart from human resource and the other things. Okay. You may see that people may be accepted to working in public health institution. People may even being trained also. We many times say that in public health facilities, people are not skilled, they are not trained, they are not properly educated. I don't really agree this. What makes me more think to disagree is like the infrastructure constraints that most of the public health facilities are not able to fulfill is one reason that all these affecting factors are kept. But the good efforts and the major strong efforts which are taken by the current government and the current health initiatives, which we find is that continuous improvement is being seen with respect to the facilities. Okay, funds and all that, which are releasing more for that part. So we require for quality professionals that if all these three challenges are to be fulfilled, you need to have a continuous training and supervision. Because without continuous training of the staff, the morale, the accountability, the effectiveness, the teamwork, all that will not improve. Supervision will give you a dialogue that will be communicated from that facility to the higher facility. Okay. This all also will reduce the documentation burden, because on supervision, inspection, assessment, if it is done, it will be seen as a very continuous activity towards the important facility. Okay. So now when we talk about the part of taking implementation of NQAS in primary healthcare, what gives me the reason that as a service provider, if a facility is being seen very poor in quality, you have to drive that facility for quality. You have to make that all the gaps that are to be there, whether it is a clinical process outcome to be improved, whether it is a patient safety that you have to take care, or preventive practices that you have to improve. The NQAS, what major benefit which has done to a lot of PHCs, sub-district hospital, district hospitals and all that, they have made significant efforts on two aspects, particularly clinical outcomes, no doubt, because clinical outcomes are more based on provisions. Clinical outcomes are more based on human resource. Clinical outcomes are more based on the improving practices actually. And resultantly, when you are making the clinical outcomes, you will find that your system efficiency will improve. Okay. But the outcome should be patient satisfaction. Without patient satisfaction, clinical outcomes, if though they are improved or your system efficiency is also being assessed, and people like us or like you or even quality assessors and all top quality professionals, even though they are saying that this facility is up to mark with the quality, but when your patient is not satisfied, there is no way that you can say, because ultimately quality um, what is and improving quality compliance is the purpose, but the patient satisfaction or the clinical outcomes will be more seen to be very efficiently handled only and only when your patient is satisfied. So the structured assessment and certification process that NQAS ensures is now moving actually with the initiatives which are now that we NQAS is improving with the efforts of Ministry and of Health and Family Welfare and NHRC of improving the accountability, improving the standardization. These two things were first being seen as a very targeted, although most of the institutions with NQAS certified have made a remarkable change. The very important question lies is whether they will be sustaining to it or not. Sustainability comes with the success. Otherwise, public health institutions in India, which are making a very strong effort, which are making very strengthening efforts, will be in a dismay. Will be in a dismay to all those situations that sustainability in quality is very important. Okay, all middle income, low income, poor countries actually face more issues of quality in healthcare only and only that with the fundings or international fundings only you cannot survive. Sustainability comes more with the efforts which are made at the uh, facility level, at the village level, particularly for this PHC. This is also very important that I want to add over here. Okay, and before concluding for this case study, I would like to say that today's discussion I made for NQAS, which has highlighted the issues of the facility, process implementation, that how they have started with, and the challenges that the hospital faced and how significant improvement were made for this part, which may be sometimes that the public health facilities are not able to bring up those improvement what the quality framework NQAS has done, but efforts should not be stopped. Okay, reinforcement idea of quality management is an ongoing process. The leaders, particularly the team efforts of the quality and even the quality assessors actually which comes, they should try actually to make the quality managers and every healthcare workers to see that your processes requires more support of the leadership. In clinical governance, we have studied it. The accountability to all level of people and even the continuous improvement which the institutions are making are more being seen valued only because although the institutions will be supported by fund, but whether utilization of that at a proper time, if it is not done, the quality will not give you the success to that extent. So this is, yeah, the quality journey. So it is a habit and a culture. Yeah, it's very important. So the responsibility lies not only to the head of the healthcare provider. I also put as an person who is a researcher, particularly for patient safety part and quality as a domain. I emphasize to see that the quality is also a responsibility of patient also. Nowadays, we need to make emphasis that patient should also be a part of the quality. They should also be given responsibility and participation of the patient, engagement of the patient is also very important, especially for public health institutions, because public health institutions are actually with lot of constraints. The Rogi Kalyan Samiti, understanding the concept of how my hospital as Mera Aspatal, schemes like Kayakal, all these have been benefiting actually to make the involvement that it is not only one person's effort as stated over here, it is more like a culture that we need to develop. Okay, so with this, I come to the end of this discussion for this case study, which was more pointing towards the inquest. Next session, actually, we will try, yeah, RKS, Rogi Kalyan Samiti, community engagement and participation. Yes, very important. Will be more, I will try to cover the JCI part. Okay, JCI or I will additionally put a 1 hour discussion, maybe like 2 to 3 hours we will take. That will be more on the, what is this, ISO. So ISO and JCA we will try, because that is also very important that we need to have an overall view where mm, how quality need to be seen as an institutional effort and a continuous effort will be more discussed. Case study discussion makes us more understanding the real facts, because you may be studying more theory, but if you have to practice, if you have to see the changes, you need to even see the outcomes with respect to what they were there as a gap. Okay, so with this I come in to the discussion of this case study. If you have any query, I will just come up with the questions which are being put over there in the chat. Okay, um, we'll try. Yes. NQuas, it is like minimum 6 bed requirement. So this particular facility was lacking. This particular case study, in this case study, the beds were 5 beds only. So that is very important and require for, yeah. But NQuas certification 25/7, actually at least a referral should be there. This particular facility at the previous end was 24/7 was not a provision which was done. This was running with only evening OPD. That too also was not with the proper sense. So this was major issue, and what I'm seeing with one of the question the student has stated over here. Then what is there written? Quality circle with champions for the NQuas, very important. Quality circle emphasis is very important for those facilities where we find the quality circles are very important, where in quality circle the responsibility is not changing, but teamwork efforts are increasing. Quality circles are very important as developing the quality champions, and quality champions are one who take major roles actually for that. SOP for overall practices being done, patient identification, yes, very important. Competency, that Kumari is asking. Biomedical waste should be segregated at a proper point of segregation generation. Yeah, that is very important, but very importantly is like biomedical waste management training is not being seen to most of the PHC people. They are not even understanding what is the real way of doing it, and the proper knowledge is not only by doing only the segregation, but how to dispose it properly, when to dispose it, what are the time protocols, what are the records. The records are not being put, and it is not being seen that the responsibility is only by your top managers or your medical officers only, but even the person who are into those facilities, they also should take that. It is not that every time the monitoring of those will be done, and this is something coming as a very shabby part to say that uh, public health institutions at this level are not much that you have to take this as a very gigantic efforts or something as a very great efforts. You need to work on those parts. Yeah. Additionally, which MT and after blood transfusion. So most of the time, what happened? PHCs are not being seen to be followed with biomedical waste management protocols and infection control practices. Even I'm seeing needle stick injuries were seeing more. Needle handling was done very, very poor. So, and yeah, I will tell, yeah, one more thing. Yeah, this, yeah, Dr. Gopi has put, yeah, very important. Should be like discussing it. Yes, comprehensive primary health care is our dream as in country India. But yes, I think more that will be solved with most of the efforts which are taken by state level team also. I will try to state you that emphasis by the state team is also very important, where you don't have to sideline everything and give it to only district level committee people only. The approaches is like the state should be a little lenient towards the importance of that district are not being seen as a smaller states among the state, but they are being seen as a very responsible entity, because even sometimes regional disparity, district-wise disparity as being also seen in major states. So PHCs are something to be very much enhanced actually. Sometimes PHCs are not located properly at their location, very remotely being placed, no proper nameplate, the buildings are poor, water supply is not there, electricity is being very poor. No, so staff over there are not inclined to work over there. They are not being seen as something very positive to that, so they are not able to contribute. So we can say that clinical outcomes are also based on the contribution of the people over there. So staff training, yes, rightly very say, is a very continuous process, and very rightly it is very important. Clinical and non-clinical outcome. Resistance to change, yeah. Yes, Pallavika has already responded. Quality is a journey, most like an habit. Yes, very rightly, very right. Dr. Gopi, it is very important that quality is everyone's responsibility at every level. Yeah, everyone's level. And I'm saying every time. Okay, so very important to say that for institutions who are going and making it like, oh, this is only a job of no, top managers. No, it is not like that. This is the job only to be seen of a people who are only in quality. No, it is not that. Quality is the responsibility of everyone. What the student has stated, and very rightly that training gives you more enhancement to that. Training gives you more new learnings, and training gives you some best practices and quality. So I emphasize that whenever you return back to your facilities, when you try to enter actually, or you try to take a role in quality, you should try to get more training aspects, more newer learnings. Improve your facilities with all those newer learnings that you have done, making it whether it is coming with the protocols, standard treatment guidelines, whether it is signages, improvement in terms of healthcare communication, which is very important part, which I find is like, and yeah, accessibility, affordability, quality, safety. Very, very good, very good, very nice. So this is how I find that a responsible healthcare worker takes not only to complete his clinical duties or by the healthcare facilities upgradation, but even providing them in a very judicious. Okay, so thank you very much. So with this, I put an end to this discussion. We'll meet possibly the next week also, and we'll make more chances for you to bring back all the support that you are putting to us for this yeah, program that we have started through the NPTEL effort. Many thanks to the NPTEL team. Thanks to my TAs, Pallavika and Amartya. Thank you very much. Thank you so much.